I'll welcome everyone for today's Smart Learning program, which is basically for the urology young consultants and the residents. And today's topic is focal therapy for cancer prostate. And the moderator for today's session is Dr. Gopal Sharma. So I request him to please start the session and welcome the speakers and introduce them to.
Thank you, ma'am. And good afternoon, good morning, and good evening, everyone. So we have a lot of speakers from different time zones. Mind you, we have Dr. Abhinav from US and Prof and Mr. Shah from UK. And I welcome you all. And I sincerely, it's my gratitude that you have all accepted for this uh, session. And without wasting further time, I would like to first introduce our chairperson for the session, Professor Hashim Ahmed, who is currently chair of urology at Imperial College London. And he needs no introduction. And he's one of the pioneers for the focal therapy. And it would be least to say that he has dedicated whole of his life to the focal therapy. So I welcome you, sir, and I would like to thank you for accepting this invitation. Now,
fantastic. Thank you very much. Thank you for inviting me to be part of this, and it's a real honor, and I'm delighted that Gopal visited us in the UK, spent a few days with us. It was always a pleasure. And thank you all for giving your time up for this. I know it's great, and there's a lot of friends on this call. So I think just to say this is the next frontier. I think we are at a pivotal point in changing towards more bespoke treatment for our patients. Both active surveillance and radical therapy have a massive place for our patients with prostate cancer, and focal therapy just fulfills that middle pathway for a lot of patients who wish to stay alive, but wish to stay alive with a better quality of life than they would get otherwise with radical therapy. It's not for everybody, and as you'll see, there's still some things to iron out, and there's still things to debate, but that's part of what we are here to do, and learn from each other. So welcome to all the speakers. I think we are starting with Dr. Ashish Khanna, who's going to talk about role of diagnostics in prostate cancer.
yeah.
So welcome, and thank you for agreeing to give this talk.
Thank you. Thank you very much, sir. So I would like to welcome Dr. Ashish Khanna for the first talk, who is a consultant at the Rajiv Gandhi Cancer Institute in the Department of Uro-Oncology and GU Services. And we'll be starting with the basics, role of diagnostics in prostate cancer in special respect to focal therapy. Over to you, sir.
Hello, am I audible? And I'll be sharing my slides.
We can see you and hear you very well.
Esteemed faculty. It's a pleasure to be a part of this. Thank you. It's a pleasure to be a part of this webinar, and I'll be talking on the role of diagnostics in prostate cancer with the focus on focal therapy. So the success of focal therapy is actually dependent on our ability to identify the candidates who will be suitable for focal therapy, which in turn is dependent on the accurate staging and grading of the tumor and the accurate assessment of the intraprostatic topography of this tumor. Finally, it is our ability to target this area which will determine how successful we are with the cancer control and the quality of life. So coming on to the traditional TRUS biopsy, this modality has a strong bearing for cancer detection on the prostate volume as well as the volume of the cancer that we're dealing with. So it may be easier for us to target a large cancer in a small prostate, whereas we may miss a lot of cancers which are small in larger prostates. This is demonstrated in one of this study of almost 25,000 odd men who underwent TRUS biopsy and subsequently underwent radical prostatectomy. And to our surprise, almost 40 to 60% of Gleason 6 cancers were upgraded on final histopathology. Other studies have also shown that the identification of a single focus on traditional TRUS biopsy is not sufficient to exclude contralateral disease, and therefore may not be a reliable, accurate prognostic information factor. So what can we do to make our diagnostics much accurate? So the first of these maneuvers could be the use of template mapping biopsies, which are precise extensive samplings of the prostate at 5 mm intervals using a brachytherapy grid. The performance of the transperineal mapping biopsies has been shown in comparison to the transrectal ultrasound guided biopsies in the PROMISE trial, where it was shown that for every Likert scoring on the MRI, the transperineal mapping biopsies have outperformed the traditional transrectal ultrasound biopsies for detection of clinically significant prostate cancer. But when we compare the mapping biopsies to the gold standard, which is the whole mount radical prostatectomy specimen, in this study, it was shown that this mapping biopsy is fairly accurate in detecting as well as localizing prostate cancers. What are the other maneuvers that can be done? It is by using MRI and targeted biopsies. The role of MRI, pre-biopsy MRI and targeted biopsies was established over transrectal ultrasound guided biopsies by the PRECISION trial, which has shown that by the use of targeted biopsy alone, we are able to diagnose significantly higher proportions of clinically significant prostate cancer, and we diagnose fewer cases of non-significant cancers, and there is a proportion of men, that is 28% in this trial, who could safely avoid biopsy. Other studies such as the MRI first trial and the other studies by Edud et al. Have shown that there is a role of systematic biopsies in addition to targeted biopsies, and studies have consistently shown that 5 to 16% additional clinically significant prostate cancers may be diagnosed by the use of systematic biopsies. In addition, the combined biopsy approach, which is the targeted as well as the systematic biopsy approach, may perform better than either approach alone. Coming to studies specifically assessing eligibility of patients for focal therapy, we may find that the evidence suggests that the use of MRI targeted biopsies with a template systematic biopsy may not be accurate enough in diagnosing the eligibility for focal therapy. For example, in this study published in the Journal of Urology, there were a subsection of patients who underwent prostate biopsy who were deemed eligible for focal therapy on needle biopsy alone. The template used was targeted biopsies of MRI along with systematic biopsies. However, when we compared these patients to the available radical prostatectomy wet mount specimen, it was found that almost 50% patients who were deemed focal therapy candidates on needle biopsy were no longer candidates for focal therapy on the radical prostatectomy specimen. It was seen that it may cause there may be Gleason upgradation, or the lesion might be crossing the midline, as was taken in the study. That frequently underestimate tumor borders and the volume of prostate cancer. Similar to this previous study, this study also at approach of MRI biopsies along with systematic biopsies may not be accurate enough in identifying patients hemiablative focal. Almost 40% patients excluded when we see their radical prostatectomy specimens.
I think Dr. Khanna's link may have frozen.
Yeah, let me contact him, sir.
No problem.
Yeah, Kiran, can we solve the problem?
It is a network issue at his end, madam.
Pardon? Network issue problem with his network.
Yes, madam.
It will be his end, won't it? It won't be our end, because we can all hear each other still. So apologies, just give us 1 or 2 minutes to see if he can find a better network connection. Otherwise, we may wish to pick up his talk maybe once he logs back in and then move on with the agenda. Would that be okay?
Yeah,
Yeah.
it's fine. Yeah.
Yeah. Would that be
Yes.
okay? Okay, fine. So apologies for that. Let's give Dr. Khanna some time to log back in. So Dr. Amitabh Singh,
Yes,
great
sir.
to see
Good evening,
you.
sir.
I have the pleasure of introducing you to talk about the costs and challenges of setting up a new focal therapy unit.
Yeah. Good evening, sir. Thanks for inviting me. And I would like to thanks also ma'am, convener of this session, for giving this opportunity to have a common platform where we can share our ideas about focal therapy. So just I'll be starting with this presentation. Topic is, can you see my slides?
Yes, sir, we can.
Okay. So topic is costs and challenges of setting up a new focal therapy unit. So I think this is a very important and pertinent topic for especially us, because in our country we have just started doing focal therapy. Until date, actually, till now we are having only two hospitals who are actually having this Sonablate HIFU system, and we have started doing HIFU recently. So I would say we are just newborn and just learning how to walk. And I think in coming future, more centers will be interested in starting focal therapy units. So it's better to discuss what are the challenges in setting up the focal therapy unit, new focal therapy unit. These are the challenges associated in setting up a new focal therapy unit. These are just to find the eligible patients. Second is to do a proper preoperative counseling. Third, just to evaluate the financial viability of the system or the program for your hospital. You must have a specially trained staff, clinicians, and not but the least, you should not have any hindrance from your manufacturer or the supplier side. Coming to the first part, that is the eligibility of the patients. So these are the eligibility criteria for the focal therapy. Coming to the clinical parameters, so PSA should be or equal to less than 20 nanogram per ml. Radiologically, the stage should be less than or equal to T3A N0 M0, but lesions should not be more than in one quadrant on MRI. Histological criteria are the Gleason score should be 7. It could be favorable intermediate, it could be unfavorable intermediate. The targeted core can have a 4+4 Gleason score. If the patient is having Gleason 7, then there is no criteria for core length. But if the Gleason score is 6, then patient must be having core length of more than or equal to 6 mm, because then it becomes a clinically significant prostate cancer. If patient is having 3+3, but core length is less than 5 mm, then it becomes clinically insignificant prostate cancer. Then they should be ideally prescribed active surveillance rather than prescribing focal therapy. So I evaluated my institutional data, whether I had a sufficient number of the patient to make the system financially viable for our hospital or not. So when I saw the patient's demographic detail between 2012 to 2016, then I found almost only 18% of my patients were eligible for the focal therapy, because we were getting a quite large number of the locally advanced prostate cancer and metastatic prostate cancer. So if anybody would have asked me at that time, then definitely I would have told them that it is not financially viable for us, and definitely I would have denied for the focal therapy. But scenario is changing. Incidence of the prostate cancer in India is increasing. And now, because of this opportunistic PSA screening, now we are getting a lot of early disease. And recently, we have seen that almost 40% of our patients, they are eligible for the focal therapy. So now, if anybody would ask me, then I would definitely say yes for focal therapy, and I can convince my management of the hospital to purchase a focal system, whether it's a cryotherapy, whether it's a HIFU, because now I am having enough patient in my kitty so that I can make it a financial viable for my hospital. If you will say, you will see in Indian setup, in Indian scenario, because for the focal therapy we need to have a very good ultrasound, also we need to have MR guided fusion biopsy system also. So in combination with all these gadgets hardware, if you'll see, then we need at least 10 cr in Indian rupees, and if you'll see in the dollars, then it will come around 10,000 million US dollar. for setting up the focal therapy in your hospital. And the recurring cost per patient will be coming around 5 to 6 lakh Indian rupees per patient. But the good thing about is that now all these insurance companies, they are providing the insurance for the focal therapy. At least in recent months, we have seen that most of the insurance companies, they are providing the insurance to our patient for HIFU. So we're not having any issues. So same thing is for the cryotherapy. There is no difference. Second point is very important, just how to do a very good preoperative counseling, because all these patients, they are not actually, you are not the first physician whom they will be taking advice for the management of the prostate cancer. They must have been talked to other physicians also, like radiation oncologist, surgical oncologist, or uro-oncologist, and they must have been advised for the radiation therapy or the robotic radical prostatectomy. Now, this is a practitioner bias also. They will always counsel negatively for the focal therapy because they are not aware about the focal therapy, or they are not having that system in their hospital. There is an initial innovation adoption life cycle phenomena also, because this is a new technology, and this is a new technology. Can you hear me, sir? Hello? Am I audible, sir?
Yes, we can still hear you. We can see your slides.
Yes, sir. So this is a basically trend. This is a very well-known phenomena in the management for every new technology. So there will be very few initial taker of the new technology. Then there will be initial resistance, backlash from the old school thoughts. But slowly and slowly, the technology will take over, and there will be basically a larger population who will be interested in adopting this technology. So the patient will ask you that what is the rationale behind the focal therapy. Then you can tell them that now we are having a randomized 3 trial, that is PROTECT trial, which has shown that the active monitoring of the patient, especially those patients who are having low risk or intermediate risk prostate cancer, there is no difference between the radical treatment, whether it is a radical prostatectomy or radiation therapy versus active monitoring. Therefore, and these radical treatments, they are come with the very decrease in the life quality of life of the patient, because they are associated with the erectile dysfunction, incontinence. And this slide has been taken from the Hashim sir presentation. I thank him for giving this presentation. So the question is how to strike a perfect balance between the oncological safety as well as the maintenance of the quality of life. Then definitely we can tell them, you must understand that the whole basically natural history of the prostate cancer will be decided by the index lesion, the most dominant lesion on the MRI, or the highest Gleason score lesion, and that can be managed very well with the focal therapy. And at the same time, you can leave the rest normal parenchyma of the prostate. And by treating only index lesion, you can strike a perfect balance between the oncological control as well as you can prevent the quality of life of patient also. Now, there are various options like HIFU, cryotherapy, photodynamic therapy, transurethral ultrasound ablation of the prostate, irreversible electroporation, that is nanoknife, or laser ablation, IRE. So if you want to have the focal therapy in your center, then at least you should have all these 2 modalities, that is HIFU for treating the posterior lesions and cryotherapy for the treatment of the anterior lesions. Now, the patient may ask you that, are there enough evidences in support of efficacy of HIFU or cryo? And thanks to the faculty, esteemed faculty on this platform, like Hashim sir, Dr. Shah, and other faculties. So now we are having enough evidences, although they are not randomized trial, they are but prospectively maintained registries, which has shown almost very good, excellent outcome in terms of oncological and quality of life aspect of the patient. And they are not very short term, they are in fact a very long term outcome, whether it's a cryotherapy, whether it's a HIFU. And although there are no randomized controlled trial, but on the prospect, but on this propensity match score, the oncological outcome over 8 years were similar between focal therapy and radical prostatectomy in non-metastatic low to intermediate prostate cancer patients. What are the guidelines says about this? So they say focal therapy with HIFU or cryotherapy can be done within a clinical trial or prospective registry for intermediate risk disease. There are no specific guidelines for the use of focal therapy in low-risk patient and high-risk localized disease. So that's why there are a lot of centers in Europe and USA which are using this focal therapy. And recently we have adopted this focal therapy in our country also. Till now we are having only 2 centers, but I am very optimistic about this thing. Focal therapy in coming future will be having more and more centers which will be coming with the focal therapy system in their hospitals. Last but not the least, what about the physician training program? Because we are having SonaBlade system and we are very satisfied with their training program. They have provided us online portal training program, advanced online simulator training program. They have demonstrated live case observation in my hospital. And they sent us basically both Dr. Ashish and me visited Dr. Hashim's unit at Imperial College. We have observed cryo also, we have observed HIFU also. And we are very thankful to him for supporting us and basically giving support in getting acquainted with the focal therapy. So in take home message, I would say apart from the skill, finance and infrastructure required for the HIFU and focal therapy, pre-operative counseling, patient selection and patients making a positive mind towards the procedure are most important factors. The most important question asked by a patient is why should I undergo this procedure? And that needed to be explained in a detailed manner. Because if you'll see the finance wise, because the cost of the HIFU is higher compared to the radical prostatectomy and the radiation therapy in our country, then we should explain in very detail that what are the advantages of this focal therapy, what are the benefit of focal therapy, convince our patient to get the focal therapy if they are eligible candidate for the focal therapy. And I see the future of focal therapy very bright in our population, especially in our country, because now we are basically heading in detecting the prostate cancer in very early stages, because most of the centers, they are trying to get the MR fusion machine, MR fusion guided biopsy. We shifted from transrectal to transperineal biopsy. So we are evolving, we are learning new things, new techniques, and we are getting basically a very early stage of the prostate cancer. Most of these are intermediate risk disease and we can offer them focal therapy. So thank you all for having patience hearing. And I think if we have any question, any discussion, we are having experts on this forum. We can ask a question to Dr. Hashim, Dr. Shah too, or Dr. Jiten.
That was a wonderful talk and really practical for those who are, so congratulations. Professor Sujata, is there time for some questions?
Yes, sir. Yes, sir. You can please go ahead. We have time till 9 p.m. India time.
Okay, fantastic. So does anybody have any questions?
Yeah, hi, Dr. Yuraj here.
Yes, sir. Good evening, sir.
Yeah, good evening. Amitabh, so you
Yes,
mentioned
sir.
that the cost is more than robotic prostatectomy. So how do you explain that? Because it's only 1 day admission. What we are doing it is almost equal or a little less than radical prostatectomy in our country. In 1 day
Sir, in my
admission, so
center,
patient,
actually, in my center, we are charging almost 5 lakh, but it's a package, but we are doing it in a private room setup. Whereas if we are keeping the radical prostatectomy patient in semi-private, it comes around near 4.75 to 5 lakh. So it is roughly equal. But if you'll see the EBRT for the patient, that means radiation therapy for the patient, the package is roughly around 2.75 to 3.5 lakh. So if you will see the cost wise, it is not less, in fact. So it can come down with the time, because now the disposable kit cost is very high. I think when we will have a lot of centers who are offering this focal therapy in our country, probably they will reduce the consumable cost per patient. And that will take the cost down of this HIFU per patient.
Yeah. Does anybody want to add to that? I think the cost issue is something obviously that is country dependent. It depends on new supply chains, and companies may be bumping up their costs when they've got a new healthcare system. Certainly in the UK, it's a day case treatment. The costs are about 3,500. Consumables costs are between 500 and 800 pounds per case. And the overall cost effectiveness, which somebody here might speak about, it shows that there is less cost over a 10-year period, even if you incorporate retreatment. So I think, so Dr. Garg kindly replied in the chat saying the cost is higher in India as only a few centers and few patients doing it. So I think supply chain should make those costs less. Great. Any other questions on that talk? There was a question on the chat from, I don't recognize the person, just says Samsung. What
Yes,
about the learning curve of procedures?
Well, I think, sir, you can tell that question. You can answer this question much better. What
I'm
about
going
that?
to, I don't want to
Yes,
say
sir.
too much, so I'm going to pass it on to other experts. So, Jiten, you've just gone through the learning curve. Arnas, you've gone through the learning curve. Well, you went through the learning curve a while back. Jiten, why don't you answer that? Because you've just left us, and unmute yourself, Jiten.
Yeah, so I would say the learning curve depends on the volumes that you're getting exposed to in your training center. So when I was at Imperial, I mean, after around 50th case mark, I was fairly confident about how to do this. And in my 1.5 years, I finished around 100 cases, half of them proctored, and remaining I was almost independent. And yes, Sonoblate does support you with 5 to 10 cases in different ways, remote proctoring, face-to-face proctoring. So if you are planning for index HIFU cases like the standard garden variety cases, you may get through, but if you are planning to extend it to redo and salvage cases, I do suggest getting some more cases under the belt and then doing those cases.
Great, thank you for that. So just reading out some of so I think there's been some comments that the prices are probably the same in India, maybe a little bit less with HIFU. It looks like all the insurance companies except Star Health are covering this, so that's fantastic. Congratulations on getting that sorted because it can be a big issue. And I guess this is a question for you to answer directly according to the talk, Dr. Singh, is how many cases per year do you need to do to sort of break even, if you like, in terms of your costs and your cost recovery? Do you have an idea?
Sir, I actually didn't inquire about this exact question that like after how many cases we will get a break even. But what I can tell you, like we are doing almost 1 or 2 cases per week right now. So we are almost, we have completed 1 year of our program. And I think I need to inquire about this, like whether we have reached the break even because we have invested almost 6 or 7 CR in Indian rupees for this system, HIFU system. Good news is that recently we bought the cryotherapy also. But cryotherapy is basically in IR department, intervention radiology department. They have started doing ablation for the small renal masses. So probably I will come to your center and I'll spend some few time for learning cryotherapy, sir.
And cryotherapy they can use for other organs, so the business case becomes much more viable, I think. Dr. Yuvaraja has just said he's done 35 cases in 10 months, and their target is 50 to 80 cases per year. I don't know whether he wants to say anything as a last comment on this. He may not be able to unmute, but he or she. I can't unmute, I think. Okay, fine. Anyway.
Yeah, I could, Dr.
Okay,
Ashish.
please, yes,
yeah,
do.
hi. So see now the cost of the equipment is very high. So even the disposable is high. So when we calculated IRR in our hospital, so it came at around 70 to 80 cases a year. And naturally, it's just a shoot off from the robotic surgery. The volume of the cases are there, but still, patient's acceptance and the physician's acceptance is still low. So I think in next couple of years, when many centers are buying, I think we'll be better off. Now Tata Hospital has acquired. Now they started doing this last week. So I think as of now we have 3 units in India. I think in couple of years, when the machines increase, I think we will be doing more and more cases.
Wonderful. So we'll move back to Dr. Khanna. I gave that session a bit more time for Q&As because I think it is quite important for new centers looking on to see if it's viable. And as you'll hear more and more talks, they'll probably reinforce the same themes. so we can catch up on some of our time. Dr. Khanna, do you want to try rejuvenating your talk, please?
If I may ask, what was the last slide that was audible clearly, if I may, or you want me to
Why
start
don't you
again?
bring them up? I can't remember, but if you bring them up,
Okay.
we can tell you where to.
2
take
slides
it
beyond
from.
the promised one.
So
carry on, carry on,
okay.
carry on, carry on, carry on. Next one. Carry on, carry on. Next one. Carry on, carry on. I think carry on, and I think from here, please.
Okay, so I'll just start from this point.
Yeah.
Am I audible and the slides are visible?
Yes.
So now I was talking that whether do we have a head-to-head comparison, whether the pathological staging accuracy template mapping biopsy is MRI targeted biopsy better. So there is one study which shown that in patients who were MRI negative, almost 25% clinically significant prostate cancers were diagnosed by the use of saturation biopsies. A head-to-head comparison also shows that in those patients of 3, 4, and 5, the rates of detection for clinically significant prostate cancers were more for the saturation biopsy. Overall, if the saturation biopsy was not performed, we would have missed around 20% of cases, and the rates of pathological upgradation were also more when we were using the targeted biopsy initially. So now if we can, there's another study which has now used the combination of these approaches, that is the MRI targeted biopsy along with template mapping biopsy, and they have shown that by this approach, the accuracy for preoperative identification of candidates for focal therapy reaches to as high as 82%. So ultimately, the conclusions are that for assessment of patients with prostate cancer, the traditional transrectal biopsy is inaccurate. The transperineal mapping biopsies and the targeted biopsies, MRI targeted biopsies, have improved pathological accuracy over the transrectal biopsy. And more so, the mapping biopsies have better accuracy over the targeted biopsies. Thank you.
Wonderful. It's really nice talks. Thank you. And I'm sorry you had difficulties with technology, so but it was great of you to carry on. A couple of questions.
How do you manage with this latest set of EAU guidelines, which just say biopsy only the index lesion and not the rest?
So we haven't actually come in terms with the EAU guidelines actually also recommend the use of perilesional sampling. The concept of the umbra and the penumbra is critical clinically significant prostate cancers. So because we have recently shifted from the transrectal to the, at this time we are actually doing a hybrid form of thing. We are doing lesional biopsies with the perilesional course, that is around a 10 mm radius around the index lesion. And at the same time, we are also doing sampling from the contralateral lobe just to acquire data for our patients. And once we have critical numbers to suggest that one approach is better than the other, we may shift to what the guidelines are recommending or whatever our data actually shows.
Yeah, it's a really good question, actually. We're continuing to do systematic biopsies for exactly the same reasons, to get more data, and we're quite keen to eventually do a comparative study just to try and hone that question down a bit more. So I think maybe the EAU guidelines are ahead of their time for once.
They are just written by people who think prostatectomy and radiation are the mainstay. So it works for those modalities because you know what cancer is. But yeah, they are. Yeah.
No, really. So I think mapping out the disease and with focal saturation biopsies, I guess, is the key. Let me just check that there's... So Dr. Shashikant, what is the ideal interval between biopsy and focal therapy? Dr. Khanna, you can answer it, or if you
So,
wish to pass it
I would
on.
actually request one of the experts on the panel to take this one.
Dr. Sidana, do you want to answer that question?
Hey,
Thank you for
Hash, hey,
joining us.
Taimur. Thank you so much for the invitation and great webinar so far. I typically use 12 months, and I think if the biopsy is older than 12 months, then I tend to repeat the biopsies. But any biopsy within 12 months, I typically use for my focal therapy treatment planning.
Do you have a minimum number of weeks that you wait, like some prostatectomists,
No.
between the biopsy and doing the focal therapy?
No, in my opinion, it's not the same rationale as prostatectomy. Where prostatectomy, I think we wait because it makes dissection of the planes easier. Here, in my opinion, as long as, patient knows the result, nothing has changed. And scheduling delays are usually 2-3 weeks. So there's no minimum period per se, just some logistics delay.
Okay. So we tend to wait 4 weeks. Again, I have no evidence for whether it's the right thing or wrong thing, but just to let some of the bleeding and inflammation settle, because I think it probably won't interfere with cryo, but the swelling and inflammation might interfere with the HIFU. I don't know. It's just theoretical. I'll never prove it one way or the other, but it sort of makes a bit of sense to me. Taimur.
I was basically going to say something similar. I mean, the problem we have is we don't really have enough data on patients who've been operated on within a few weeks. Part of it is the logistical challenge of getting a biopsy reported and the patient in for surgery. And generally speaking, most healthcare systems, you're talking a few weeks there anyway. But when you do early MRIs on these patients, even after biopsies, you see a lot of changes within the tissue. So the worry is always, as Hash says, is whether any of that remains afterwards. But actually, I just don't think we've got the data to say whether it makes a difference. But most of us naturally wait at least 4 weeks.
I mean, I can say there are few early studies about doing prostatectomy within 2 weeks. So after 2 weeks of biopsy, because what is happening with transperineal biopsies, you're not going through the rectum, and it is very different than a transrectal approach. I have seen robotic prostatectomy after a transrectal biopsy at the 2-week mark. It wasn't good. But I have equally seen robotic prostatectomy after a transperineal biopsy, and the planes were actually very good. So at one point, we were thinking that Imperial has this rapid pathway. Can we make it rapid treatment pathway? So you do a biopsy. Now with the new guideline of just lesional and perilesional sampling, you hardly need 5 cores. So a lot of our practice in Portsmouth has moved to just 4 or 5 cores and out. And in that, it may allow very good dissection even at the 2-week mark.
Yeah, fantastic.
Yeah, so,
okay.
But I'll lower my hand.
Sorry.
Don't worry. We'll carry on. We'll lose out on time if we just stay
Okay,
on top.
let's if you don't mind. So Professor Sujata, if you're happy, we'll Gopal if we carry on.
Yeah, please do carry on. There is no time. And it's like
Okay.
even if we exceed 10 minutes, nobody would mind.
Fantastic.
Don't worry.
So the next session is a pro-con debate. Hopefully it'll be friendly. Both Jiten and Arnas get on with each other, but they might start to attack each other today. So is focal therapy ready for prime time? I think it's always useful to rehearse, even if you believe in something, rehearse the arguments for why we shouldn't do it, because it allows us to improve and ask difficult questions of ourselves. So we all should be innovators and improve care for our patients. So it's my pleasure to welcome 2 of my eminent colleagues, Mr. Arnas Rakauskas and Dr. Jiten Jaipuria. So Arnas, if you go first, thank you for joining us. And if you could introduce yourselves and say where you are and what you're doing, that would be also quite useful, just so the audience has some context in your background as well.
Hi everyone. Thank you very much for the invitation. Thank you for introduction, Hash. So I am currently undergoing a robotic surgery fellowship at UCLH. and I trained in Switzerland as urologist, and I also did a focal therapy fellowship 6 years ago at Imperial College. So that's my background. And I'll let Jiten introduce himself.
Hi, so I am currently a consultant at Portsmouth University Hospitals NHS Trust. I do also work with Imperial for focal therapy lists and cases. And my basic training in robotic surgery was in India. And I offered the whole gamut of modern prostate cancer care treatments, including robotics, focal, and brachy as well.
Great. So I think it's Arnas first, who is going to speak in favor of focal therapy being ready for prime time. If we have problems hearing or transmitting, if you could switch your video off, that might be, so you might hear me asking you to switch your video off, but so far it's been fine.
Can you see my screen?
We can, but it's split up for some reason.
Is it okay now?
It's got a weird view. We can't see any slides.
You can't see my slides. Let me try again. What about now?
Now we can. Fantastic.
Fantastic.
Got a beautiful view of Lausanne.
Yes. So that's Lausanne. That's the city where I trained as urologist in Switzerland, just on the lakeside. So I'll try to answer today the question in the presentation. I have one conflict of interest to declare, and that is that I'm currently undergoing a robotic surgery fellowship at UCLH. So you can take this as conflict of interest or actually as a reduction of bias in my own presentation. So short overview, I only have 8 minutes, so I'll just speak quickly about rationale of the focal therapy. I'll present you with the most important evidence, and I'll try to answer the question in the title. So in terms of rationale, I think I have to set the ground for focal therapy with these 2 large randomized controlled trials, especially the PROTECT trial that we already have 15-year outcomes. And basically, they show very simple thing. The benefit in terms of prostate cancer specific survival is limited to only men with very long life expectancy when comparing radical treatments to active monitoring. So that is extremely important when we counsel our patients for treatments. Now, the second thing, if we look at a similar trial from a non-PSA era, the SPCG4 trial, where they compared watchful waiting to radical prostatectomy, we can also see from this figure that there is some proportion of men who will die despite that we treat them. There is also going to be a proportion of men who could avoid treatment because they will still outlive they're going to die from other causes. And there are also going to be only a tiny proportion of men, or at least not as big as we would like to, who would actually benefit from treatment in terms of prostate cancer survival. And not only our impact is not as big as we would like it to be, we also cause harm with radical treatments. So again, this is from PROTECT. We clearly see that in terms of erectile dysfunction and urinary incontinence, patients do get significant side effects that impact their quality of life. And so what should we do in this situation? That I think there was a paradigm shift, and I will quote Hash, who said in this paper that prostate cancer is the last solid cancer in which treatment is directed towards the organ and not towards the cancer. In most of the organs in our body, we prefer organ-sparing approach or organ-sparing surgery when needed, and we prefer not to remove the organ. But in prostate cancer, we choose to treat the whole organ in most cases. So, and there are reasons for that. Well, prostate cancer is multifocal. we did not have accurate diagnostic tools, and also we did not have technology to deliver focal therapy. So I'll address all of these reasons one by one. So you already saw this slide from Dr. Singh's presentation. Our understanding about multifocality has changed. So we understand that the index, in most cases, there is this index lesion within the prostate that drives the natural history of the disease and has the potential to progress, to metastasize, to spread. And by treating this index lesion, we can cure most of the patients, even when leaving the low-grade, low-volume cancer behind. We know that these low-grade, low-volume cancers, they do not impact the natural history of prostate cancer. In terms of diagnostics, we now have MRI for many years now. We know that it works. It can precisely localize the lesions within the prostate, and with help with targeted biopsies or template biopsies, we are able to localize precisely the cancer within the prostate, so we can deliver the treatment also precisely within the prostate. And in terms of technology, so this is a paper published a few years ago in European Urology, a systematic review on focal therapy. And again, we have 72 studies, almost 6,000 patients, and 8 different energy types to deliver focal therapy. We can either divide them to thermal ablation or non-thermal ablation, and the most known thermal ablation treatments are HIFU and cryotherapy, while the most popular non-thermal ones are IRE and photodynamic therapy. And I think my colleagues will still speak about this later, but again, you need these multiple technologies because each technology suits better a different part of the prostate. Now, the people who are proponents of focal therapy, they will say there is not enough evidence, and especially not enough RCTs. And it's true, this is the only RCT that we have that is completed in focal therapy. And it's also completed in a patient group that is, I would say, is not where we, not that patient group that is most interesting to us for focal therapy. It's in men with low-risk prostate cancer against photodynamic therapy. And while it did show that patients, they did have a better failure-free survival, I think what's important from this trial, though, is that it showed that the side effect profile in terms of urinary continence and erectile dysfunction is quite low from focal therapy. And while there are ongoing RCTs and where we are waiting long-term results, we do have RCT data for toxicity profile of focal therapy. And this is from the PART trial, 1-year outcomes, comparing the urinary, the incontinence rates and the erection firmness from the PART trial. And we can clearly see that focal therapy HIFU performed much better than radical prostatectomy in terms of genitourinary toxicity. And while we don't have the RCTs, we do have a lot of good prospective data on focal therapy. Again, this is one of the papers that's already shown. Probably the biggest multi-center prospective study, including about 1,400 men, 15 years of experience, and at median 7 years follow-up, 70% of patients in this study had failure-free survival, and 90% of the cohort were either intermediate or high-risk cancer, prostate cancer patients. Another study that I would like to show is also from Imperial College, from Mr. Shah, where basically they compared failure-free survival with propensity score matching. So they matched the baseline variables of patients undergoing focal therapy or radical prostatectomy. And what they found is that, again, the failure-free survival was similar at 3, 5, or 8 years for focal therapy or radical prostatectomy. So is focal therapy ready for prime time? I would say yes, but there's a caveat. I would say there should always be, focal therapy should be for the right patient. And then definitely it is for prime time. So what are those criteria? So first, patient should need treatment and he shouldn't be undertreated or overtreated. He should have a corresponding MRI and a biopsy, also called the index lesion. The lesion has to be accessible for your focal therapy modality, and you should be able to obtain a treatment margin around that lesion. There has to be a functional value for the patient in terms of his urinary function and sexual function, and the patient as well has to accept the paradox of the focal therapy and its solonomes. And as it's very trendy right now, I asked also ChatGPT the same question, and I think ChatGPT gives a nice resume to my presentation and says that it is very promising. We're still waiting for the data, but again, it is very viable solution for patients in specialized centers with proper counseling. So it's a yes from me. Thank you for your attention.
Wonderful. Thank you very much. We'll take questions at the end. So straight on to Jiten to argue against focal therapy.
So let me share my slides. Yep. So thank you, Prof, and thank you to the organizers for giving me this opportunity. So there is a conflict of interest, like with Arnas, both of us do focal therapies. And from Indian perspective, yes, I did come and train formally in a fellowship. The outline of my today's talk is to first understand the epidemiological basis of prostate cancer treatment in context of focal therapy, and then understand how a focal therapy program actually works. So then you can decide if focal therapy is meant for you. So I have slightly tweaked the topic. My topic is actually going to be, is it prime time for focal therapy in India? So because our audience is predominantly Indians today, and it's not just students, I see thought leaders in the audience, I see very senior faculty members. So when I came to Prof for training in 2021, at that time, it's an evolving program in Imperial, and this is what the general indication for focal therapy was. And it still is in many parts of the world, where there has to be an index lesion, Gleason 7, 4+3 or 3+4, and you could have some insignificant Gleason 6 in non-index areas. And then so you see a focal lesion, you ablate the prostate focally, makes complete scientific sense. And that's how we go. Now, Imperial has evolved and we are even allow Gleason 8 in targets, but I think not many other centers have come up to that standard yet. So coming to part one, understanding the epidemiological basis. So a lot of understanding for prostate cancer comes from the screening trials that we did over the decades. And people remember them for establishing PSA as a failure. But in my view, the biggest contribution they ever did was that we understood clinical and natural history of prostate cancer. And yet clinicians do talk little about it. So the concept of screening trial was essentially that people die with cancer with time. And if we could find a biomarker that increases before deaths, so if we chase that biomarker, then maybe we can prevent a death. So that's the basic concept of a screening trial. And it all started with a finger test, so our old DRE. So in the SPCG4 era, they just looked at clinically palpable tumors. And the median PSA in that era was 13. And what that trial essentially showed was that was the first trial to clearly establish that Gleason 6 and Gleason 3+4, even when palpable, patients did not benefit from active treatment of cancer. Only 4+3 and higher benefited. Now, later on, PSA screening started becoming somewhat prevalent. And when PIVOT trial came in, then we further understood that yes, even those with intermediate risk stand to benefit from cancer treatment. And if the PSA is more than 10, those patients stand to benefit as well. In the era of PROTECT trial, even more PSA testing started happening. And then we realized, yeah, we can treat intermediate risk as a group, but a lot of them may simply be observed and then even do well with a delayed sort of treatment. So what essentially happened with screening trials was, so SPCG4 came in and broke this block into top and bottom halves. And then it said that the top half benefits and the bottom half does not. Now, as we introduced PSA as a screening test and replaced the DRE finger, then essentially the new screening test started chipping along the edges. So then we realized, yeah, some Gleason 3+4 can move to the top. And then as we made PSA testing more prevalent, then again, the chipping along these two edges became even more. So then we realized, yeah, okay, 3+4 can be treated, but can wait as well. So if we look at the epidemiology of how screening trials have worked, so our biomarker, if it's finger, then this is how it goes. But PSA is slightly, because it's not completely perfect, it fluctuates up and down. So it covers more area under the curve. It is still better than a finger, but not entirely perfect. So this is where we stand today. But there is one common thread that has been common across all screening trials, and that is that patients with a general risk population profile don't benefit from active cancer treatment for localized disease before living beyond a decade. So this is very important in context of India and low middle income countries from a health policy perspective. And there are some uncomfortable truths here. So just from statistics, epidemiology, and mass, if we run a randomized prostate cancer screening trial in India today, what is it likely to show? So we always in India thought that, India is somewhat different from the West. But when we look at actual data, the mean age of a robotic prostatectomy cohort in India is 64. This is a recent study from AIMS. And it's no different from what we see in the UK, where it is 63. But the life expectancy in India is 67.74. And while in UK, it is 80.7. So an average UK man at 64, when he goes for a prostatectomy, he still has 15 plus years under his belt, while in India, that number is just less than 5 years. So this is the uncomfortable truth, which we need to understand. And even if today we magically replicate the UK practice where we introduce widespread PSA testing and fund it nicely, so even when UK did that, the mean age at diagnosis dropped to 59 years. So we stand today at around 64 years. Even if we try our best with what we have currently with PSA testing, we'll at most go to 59. Even then, we don't reach the 10-year future life expectancy threshold. So in India, the truth is that only the fittest men that shall outlive generally everyone around stand to benefit from active prostate cancer treatment in India for GG2 or GG3 localized cancer from an epidemiological perspective. You don't need to run a randomized trial for it, it will fail. In the playing field of intermediate risk cancer that focal therapy claims, watchful waiting would actually be the default choice for GG2. And watchful waiting or AS would be the default choice for GG3, uniquely in our context, and for that matter, whole of South Asia. So PROTECT trial actually gave us a lot of nuanced data, and we can actually tell what potential range of benefit could focal therapy offer for Indian patients with GG2 and GG3 today. So there in the PROTECT trial, you get a predict calculator. And I put the numbers from AIMS into that calculator. So if I put the PSA median level of 14, which is what AIMS sees, and with T3 disease with a GG3, which is the limit of a general focal therapy case for a 64-year-old, then Indians are not going to live beyond 10 years in general. So if you look at the first graph, it shows that on an average, an Indian patient, even if he's like very fit, he stands to gain only 1 year of extra life in the next 10 years. While if it was same applied to a UK citizen, he would stand to gain at least 2 years because they are going to live 15 years. If I move it to Gleason grade 2, which is 3+4, again, PSA 1464 age, then the benefit for Indian patient is likely to be just 5% extra survival, meaning 6 months of extra life. While for a UK citizen living 15 plus years, it would still be more than a year. So it's easy to prophesize that now we understand how screening trials work by chipping along the edges of the block. If we introduce MRI, let's say we go full house and we say we will bring MRI, every Indian will get an MRI, then we can guess what will happen actually. So MRI will simply allow us to further discriminate those who would stand to benefit by continuing active surveillance. Because in the PROTECT trial, we know that 50% patients could continue active surveillance, 50 had to discontinue. So MRI is likely to guide us, discriminate those patients better, and not change the management of Gleason group 1, 4, and 5. So don't hope that from the MRI. In context of India, it's all about life expectancy. So MRI, because it chips along the edges in the Gleason 7 area, where it makes a meaningful impact, it will have no epidemiological impact for GG2 and marginal impact for GG3. So in summary, our epidemiology warns that the way our current life expectancy, even if we screen everyone with MRIs, only GG4 and 5, if picked early, would get any real benefit because they risk dying within 10 years if not timely treated. Those with GG2, meaning Gleason 3+4, are at a high risk of overtreatment in India and do not stand to significantly benefit from early diagnosis. And the benefit to GG3 shall be marginal. So the reality in India right now is we are transitioning from SPCG4 era to pivot era with mixed levels of PSA testing. Our PSA testing levels are low, and median PSA levels at diagnosis are 14 at AIIMS, and they match the SPCG4 data, which is 13. In the PROTECT trial, the median PSA had dropped down to 4.9, while in pivot it was 7.9. So now coming to the last part of the talk, and already my colleague has told it nicely, and Ashish as well, and Dr. Amitabh as well. So there are pillars to a focal therapy service which make it successful, and all you need to see is your service ready for it. And the first pillar, yes, Ashish spoke about diagnostics. So MRI is quite essential. I mean, that's the backbone of focal therapy. So you need to have a dedicated or experienced uroradiologist, and there should be a process for quality improvement there, and there should be a process for feedback in place. I know India, that these processes are not really robust. And secondly, of course, we need to develop the ability to accurately do a nice biopsy. So as focal therapy trainees, we learn to read MRIs like the back of our hand, and we don't depend on radiologists that much. But there are challenges facing diagnostics even in advanced countries like UK. So the Precision Study Group found that in the Precision trials, only 60% MRI scans were actually good quality criteria. So this is something even UK is struggling with most widespread MRI adoption in the world. There are challenges with diagnostics in the current EAU guidelines, which recommend that you should only sample the lesion or perilesional areas and leave the rest of the prostate. So this is my Portsmouth University case. So you can easily see this is an index lesion here, and this is it. So if you go by the guidelines and just sample this and leave the rest of the prostate, so this here was 4+3 in the target, but there was 3+4 here, 3+4, 3+4, 3+4, 3+4. So this is a very different case. You would miss all of that if you just would sample this index lesion. So this was MRI said T2A, and PSMA PET was negative. In the target, it was 4+3, 3+4 in other areas. Now, I went ahead and took this prostate out. And because I work based on risk assessment models, because I know the limitations of PSMA PET, where it's only 50% accurate at best. So for this patient, the lymph nodal involvement probability on my nomogram was 29%. So I took the prostate out, I took the lymph nodes out, and lymph nodes were positive. This was T3BN1. So you need to look at you need to have a deeper understanding, and you need to make a mental picture of the case as to what's staring in front of you. A double-digit PSA, multiple quadrant disease, it's a different beast. So the next pillar is energy delivery. Of course, India currently has HIFU in multiple centers now, 3 now, and Rajiv Gandhi Cancer Institute has got on to have cryo. You need to have at least HIFU and cryo as your energy modalities. Otherwise, you don't get the full, benefit out of focal therapy, and people just think HIFU is focal. No, there is more to it. The third pillar is, and this is very, very important, this is what you will realize when you actually start doing focal therapy in high numbers, that once you do a focal therapy for a case and then you have to follow it up, you need to still apply the principles of active surveillance. And when I came to UK, I had to learn active surveillance actually, because in India we never practiced it. It has its own learning curve. Don't take it lightly, because even now we are learning how to properly do active surveillance. It is only now that we understand that when we do serial MRIs, how do we interpret those changes? Is a 1 millimeter increase in lesion diameter significant, or it should be a 50% increase in volume, or it should be a 15% increase in diameter? It's only after 10 years that US now finally understands with the Prius trial that the only thing that matters in active surveillance follow-up is a grade change and a T3 disease. It took them 10 years to reach that conclusion, because earlier they would discontinue active surveillance. Even if it became 3+3 became 3+4, they would discontinue it. You can continue it. So in focal therapy, like in brachytherapy or in radiotherapy, you will find failures if you look for them. So this is a nice study of 91 patients where they mandated compulsory follow-up biopsies at 6, 12, and 36 months following HIFU. And 40% patients were around more than 50% patients had actually cancer recurred on the biopsy. So when we follow up with biopsies, we will see more failure. When we follow up with MRIs alone, we will see less failures, simply because those insignificant recurrences will probably be masked. So the principles of active surveillance actually apply to 50% of focal therapy patients, even during follow-up. So people say focal therapy is a replacement for active surveillance. No, you need to know good active surveillance to do good focal therapy.
Jiten, I know you've got quite a few slides I could see from the, so can I ask you to wrap up in the next 1 minute, please?
Yeah, this is the last slide. So the problem I have is that from India, there is not a single active surveillance cohort published, and we are still struggling with accurate characterization of lesions, and we find 50% of our patients upgrade. So should focal therapy be written off from India? No. India is a large country with huge heterogeneity. Because of our sheer size, I think we have the numbers of patients who would benefit from it, and pioneering institutes have come forward with this treatment. And it is not for me to tell you if focal therapy is for you. It is for you to decide based on audit of your own patient cohort. Do you have those deserving patients coming and seeing you? And if yes, centers of excellence in India should create space for innovation and future growth. Thank you so much.
Wonderful. Thank you both. Tour de force from both of you. Any questions? I have a Santosh. Do you want to ask your question, or shall I read out the comment? I think the comment was, India is very diverse, and oversimplifying life expectancy is probably not a very fair reading of what's going on because of that diversity. So Jiten, what do you say to that?
Yeah, I told it in my last slide. India is very large, gigantic, heterogeneous. We have a cohort of patients who would match Western Hemisphere in terms of all parameters, and they do stand to benefit. But as a cancer screening trial perspective, as a population study perspective, if you throw focal therapy to India, you will not see survival benefit. That's what I want to emphasize.
Sorry, now I am unmuted. Jiten, Santosh here. Can you hear me?
We can hear you. We can hear you.
Yeah. So if you see, we have the whole spectrum of healthcare services available. But if you agree with me, the ones who go for prostate cancer screening and the PSAs are actually the more educated and the more rich population. So that is a population which will match with the cohort of the West. So you cannot treat them with the ones who are not having access to primary healthcare. So those patients probably have to be treated at par. All the data that you see of the prostate cancer is actually coming from level 1 cities like Delhi, Mumbai, and now Bangalore and Hyderabad and other places. So I think we are already there for everything. It is as long as we have enough treatment for prostate cancer, we should also have enough treatment for focal therapy, because that number is increasing very fast.
I agree with you.
So it's a really good point. Even in the UK, there's variable regional diversity, isn't there? Okay.
Yeah,
Any other?
even in Portsmouth, where the GP practice is actually the lowest in the UK. So I find a lot of my high risk cohort case mix is 90%, while in Imperial it was 50%. The average UK is 30%. So I actually do Indian practice here.
Yeah, so good point by Dr. Ashwin. Even that population that Dr. Santosh is alluding to would constitute 100 million plus. So, and he also says great presentation. So a question to Arnas. Since you've gone to UCLH, you're doing a purely robotic. Has your views on focal been tempered? Is it still the same? Do you think the same patient population that you were treating back in Lausanne at Imperial is similar, or have you been able to sort of balance it somewhat?
No, I don't think starting a robotic fellowship changed my view on focal therapy. I am a big believer in personalized prostate cancer care, and I think it's also adds to the discussion that was just had, that I think we always should have a per case discussion whether or not focal therapy can benefit that patient. And again, for every patient, we have to evaluate his baseline characteristics. We have to see his life expectancy based on his comorbidities and his lifestyle. And we should always tailor our treatments. And I don't think that, again, my threshold, my personal threshold for focal therapy would be probably Gleason 4+3 cancer in patients who did not have any treatment before. And for salvage cases, I think any Gleason score is possible for focal therapy. So I think I had these I had these characteristics were the same before I started my fellowship and before I worked at Imperial as well. So yeah.
Fantastic. Thank you very much. Good. We move on.
Can I add one important point for India?
Go on.
So
Go on.
we talked about index cases only, but we missed a huge cohort of salvage focal therapy treatment, which is actually where India needs it much more, because even in India, more patients get treated with radiotherapy today than robotic prostatectomy. And in US, radio recurrent prostate cancer is the 4th most common cancer. And I think in India, it's also a huge volume there. So while salvage prostatectomy is not a scalable modality, you need a highly experienced surgeon and a very good patient to be offered that. But salvage focal therapy is much more scalable. There is much lower learning curve, and it can be delivered at a scale which robotic prostatectomy cannot match. So for this reason as well, I request that centers of excellence should explore focal therapy strongly.
Great, that's a good point. But after you've gone through a learning curve for your primary cases, because salvage ablation is tough and you could cause disasters if you go straight into that. But it's a really good point that population is untapped at the moment and they're going on to systemic therapies generally. Dr. Ashwin, we'll come on to your question, I think, for the next session, because I think it's quite pertinent there and the speakers might even cover it. So it's my pleasure to welcome Mr. Taimur Shah from the UK and Dr. Abhinav Sidana to talk about how they do focal therapy with HIFU or cryo. But I'll get them to introduce themselves first. So Dr. Sidana, if you could introduce yourself first, and then Mr. Shah. If you unmute. There
Yes.
you go.
Thank you, Hash, for the intro. I'm Abhinav Sidana. I'm a urologic oncologist at University of Chicago and have been performing focal therapy for the last 6 years. I really appreciate this invitation to be here today and see you all and give a talk on prostate cryotherapy.
Thank you. Taimur?
Yeah, no, thank you for the invitation. So it's probably one of the few panels that I've sat on where I can actually say that my name is Taimur Shah and not Taimur Shah as it's known in the whole of the UK. So that's quite nice. I am a urologist at Imperial. My PhD was actually in focal therapy, both in primary and recurrent disease and MRI-based imaging for diagnosing recurrence. And I currently perform focal therapy and robotic prostatectomy. And it's a pleasure to be here today.
Wonderful. Do you want to? So it's Taimur Shah to start off, I think.
Yeah, I will share my slides, and I hopefully won't overrun, because I've been trying, as the presentations have been going on, to remove and add slides, because there is a degree of duplication between them. But so I apologize in advance for it, but I've left all of them in. And the title I've been asked to talk about is How and When I Do HIFU. And HIFU, as many are aware, is a treatment that's been backed by years of innovation, years of evolution, and worldwide, thousands of patients have been treated. We now have long-term outcomes, and we actually have comparative and randomized data. And probably the key question, we've talked about this a few times already, is about who should have treatment. And there's a lot on this slide, and I will just simplify it. It's essentially anyone with localized intermediate risk disease, so grade group 2 and grade group 3. We generally will permit contralateral grade group 1 disease, but actually more and more frequently, we're actually allowing patients with low volume Gleason 3+4, so grade group 2 disease, to actually also be suitable, because these are patients generally we would monitor on surveillance. We wouldn't necessarily be treating them. And I put that on the bottom right. I put a table where a lot of people worry about multifocality, and this is some of the debate we've been having around the EAU guideline change. The vast majority of multifocal disease actually ends up being Gleason 6 disease. So outfield disease is generally low risk. And when you apply those criteria to the whole population, this is UK cohorts, but and it'll apply to some of the Indian cohorts looking at the data. When you apply those criteria, almost 1 in 2 men with localized disease is suitable for some form of focal ablation or HIFU. And as I said, we now have thousands of patients who've been treated, predominantly with intermediate and high-risk disease. And now let's talk a little bit about how I use HIFU, how I deliver treatment. And this is using the Sonoblate device. And essentially, it's dose escalated, and I'll explain what that means. It's visually directed, and it's energy modulated. And dose escalation means a layering of treatment over your target lesion. And we do this at least 3 times in primary disease and only twice in salvage due to some of the higher risk and side effects. And essentially, by layering this quadrant, you actually increase the amount of energy you deposit over your target lesion. And what we find is, when we did this, we found a 50% reduction in our in-field failure rates. It's visually directed, which means in real time, we have an ultrasound image giving us feedback on the energy being deposited. You may have heard about popcorning or Yoshida changes, and these are these very bright grayscale changes you see in ultrasound, which indicate areas of very high energy deposition and tissue damage. And if you're getting these, you know you're getting adequate energy levels. But alongside this, we also have something called the TCM, and this uses RF backscatter to give you a secondary readout on whether you're achieving adequate temperatures. And if you're starting to get these orange boxes, it means you're getting temperatures potentially as high as 90 degrees Celsius. And then finally, energy modulation. Energy modulation is the ability to control the amount of watts I put in. And actually, I can increase it and keep increasing it till I get these changes visually and until I get those changes on the TCM, which again gives me a lot of confidence that I'm actually delivering enough energy. And then on top of that, we also have this safety feature built in. It's called the RIM, and it detects the pixel count within the kind of around the rectal wall. A lot of people worry about rectal injuries and near field heat deposition. And what the RIM does is allowed me to increase this power safely and also be able to say that I'm not getting this energy deposited around the rectum or near field changes. And I'll skip this slide for time, but essentially when you put all of this together, when you use this treatment protocol, we find that we actually get quite robust oncological outcomes with HIFU. This was the last published analysis of almost 1,400 men, and we find that about 80%, so 4 out of 5 men, are free from any radical treatment at 5 years. And actually, that number is relatively similar at 7 years. And the key number I like to quote to patients is that almost all patients are alive, and the rate of metastases is around 1%, if not lower. And actually, so it means we're not doing any harm to these patients by having a focal therapy upfront paradigm. And the vast majority of these patients actually had, as I said, intermediate and high-risk disease. And this data has now been independently validated by actually a group who've been, in my opinion, not the biggest proponents of focal. They've been actually quite anti-focal, and they have now looked through our UK national registry data and effectively find that the outcomes are mirrored from our cancer registries, from our local cancer registries. And that is that 80% of men are free from any local salvage treatment at 5 years. Almost all of them are alive at 5 years. And if you look at the Kaplan-Meier plots at the top, there's very little difference between grade group 1, 2, and 3 disease. And the vast majority of patients had intermediate or high risk intermediate risk disease. This slide has been mentioned a few times. This is comparative data that we published a few years ago showing no difference in failure between patients having prostatectomy and focal therapy. And this number that keeps coming up is actually really consistent. Doesn't matter how you run the analysis, and that's 80% at 5 years are free from salvage treatments. We did incorporate a redo treatment, and I will talk a little bit about redo treatment in later on in the talk. But we're also now starting to get randomized data through on HIFU. This is the FARP study from Norway, and it's not reported its oncological outcome yet, but it randomized 200 men to either HIFU or prostatectomy, and it has started reporting its functional outcomes. And what we can clearly see, which is what we've been seeing from our non-randomized data, is a significant benefit for focal therapy with HIFU. So in terms of incontinence, they found a 6% rate compared to 42% after prostatectomy. But even more stark is the difference in erectile dysfunction. 9% had erectile dysfunction after HIFU, and I quote 1 in 10 in my clinic. It was almost 75%, so 3 out of 4 men had erectile dysfunction after prostatectomy. So big differences now proven within a randomized setting. And this means that if you look at all of our data, what we find is that about 4 in 5 patients at least over 5 years after HIFU will be failure-free. But we also need an understanding about what do we do with the other 1 in 5? How do we manage these recurrences? And a significant number of them will actually be eligible to have redo treatment. And that's roughly speaking about, as I say, about 1 in 4 of that group, so the majority of that group. And then about 1 in 10 overall will go on to have whole gland treatment subsequently. And this is in our data. And how do we find these recurrences? Well, we've now published a scoring system called Target on the use of multiparametric MRI after focal therapy for the detection of recurrence. It uses dynamic contrast enhancement as your primary sequence and gives you a score from 1 to 5 on the risk of recurrence. And it helps you decide who maybe should and shouldn't have a biopsy afterwards as well. And this is I'm just going to highlight the first case, and this is a patient who underwent left-sided focal ablation. You can see on the far left, the T2 weighted images shows just fibrosis, so you can't really say much on it. But if you look at the ADC, you start to get some restricted diffusion. And then when you finally look at the DCE, which is the picture on the far right, you get this early focal enhancement, and this patient's biopsies came back positive. And this is a target 5 lesion. But it's no use finding these recurrences if we don't know what to do with them. And we have data on this. So I, in clinic, will quote about 1 in 10, approximately, for a new erectile dysfunction, and I'll quote between 1 and 2% for new pad usage. And actually, the numbers I quote for patients having a redo are exactly the same. There is about a 1 in 10 risk of new erectile dysfunction with a repeated focal therapy procedure for someone with local recurrence, and about 1 to 2% new pad usage. So actually really quite good numbers, particularly when someone asked earlier about what do you do, how do you decide between salvage prostatectomy and redo treatment? Well, these are some of the numbers that push you towards redo treatment. But actually, one of the benefits of focal therapy in general, but also with HIFU, is that we have a lot of data on what you do afterwards. And actually, if they did have a salvage prostatectomy, you're again not generally doing any harm. The vast majority of patients have very good functional outcomes. And this is a select group who had quite high-risk disease, so they maybe had higher rates of positive margins. But I think the key number is that the vast majority could have a nerve spare, and 8 out of 10 were actually continent. And the radiotherapy data is very similar. If you have to have radiotherapy for someone who recurs after HIFU, the subsequent failure-free survival is not that different actually to someone who maybe had it in the primary setting. So you're again not doing any harm to these patients. And so in conclusion, with HIFU, we have worldwide evidence on thousands of patients that we treated, and I haven't even brought in some of the French data that's been published recently, and it's predominantly in grade group 2 and grade group 3 disease. The best outcomes in our hands are with dose-escalated layered treatments, and with that, we have very robust long-term outcomes, including comparative data, including early randomized control trial data. We now have a good understanding of how to manage recurrences, but we also have a scoring system that we can use to help detect recurrence. Thank you.
Fantastic. Thank you very much. Abhinav, do you want to go next?
Yep. Thank you again for the invitation. I'll be discussing how and when I do prostate cryotherapy, mostly focusing on my patient selection and my technique. These are the disclosures for my talk. We'll start with discussing the mechanism of action of cryoablation and why it should work. Identify appropriate candidates, which is answer to when, and then how to do this procedure. Cryoablation, as most of you are already familiar, is done through transperineal cryoprobe needle insertion. Patients are in dorsal lithotomy, and the needles are inserted through which argon gas runs and cools the prostate tissue. It leads to freezing of the prostate tissue, causes cellular swelling and rupture of cell membranes, releasing intracellular contents outside the cell. And during the thaw process, there is increased fluid shift and causing further cellular swelling and cellular rupture. And finally, cryo causes vascular damage. And because of the endothelial damage, there is ischemia, which leads to apoptosis and further cellular death. So I perform cryo for I perform two types of treatments with cryo. I do focal cryos and whole gland cryos. And we'll start with selection criteria for the focal cryos, which is similar to what Taimur alluded for HIFU patients, usually Gleason 7 disease, PSS less than 20. In radio recurrent cases, I sometimes treat high-risk prostate cancer with cryo focally, but those are rare cases. Mostly it's limited to grade group 2 and 3 prostate cancers. In my opinion, one of the biggest factor for success is finding unifocal and unilateral disease. Focal therapy can be performed in multifocal disease, and I routinely perform it, but I feel the failure rate is lowest in patients who have a unifocal and unilateral cancer involvement, and they have a discrete MR visible lesion which can be targeted and destroyed and followed during the surveillance to ensure there's no recurrence or residual disease. The couple of other factors you have to keep in mind for cryo is absence of high-risk features, which are extensive seminal vesicle invasion or extensive EPE. In those cases, probably focal cryo might not be the best option. And cryo is a thermal energy modality, so it can damage vital structures if those are not properly taken into account. So proximity to sphincter, proximity to rectum, and proximity to urethra should be kept in mind while selecting patients for focal cryo. But in general, if you can destroy all clinically significant cancer with preservation of at least one neurovascular bundle and urethral sphincter, the patient should be eligible for focal therapy, focal cryo. So this is an older data from cold registry, and even back then when there was MRI was not as widely prevalent, the outcomes of focal cryo were pretty excellent. The freedom from 5-year failure rate was 70-75%, only 14% positive biopsy for Gleason 7 disease. Continence outcomes were excellent, 95 to 99%, and a significant proportion of patients still maintained erections, 48 to 69%. When I started my career at the University of Cincinnati 6-7 years ago, most patients were getting focal cryo through cognitive treatment. And actually, a lot of them were getting template-based treatment. It was called focal cryo, but treatments were like these, hemigland. And if you look at this treatment, there's a lot of margin anterior to the tumor, decent margin laterally, but there's not enough margin medially. And my hypothesis was that we have to have a margin circumferentially around the lesion instead of just doing a template-based treatment. Template-based treatment can provide a lot of margin in one aspect of the tumor, but probably would compromise margin on other aspects of the tumor. So 6 years ago, we started doing MR-guided focal cryo. This is an Artemis machine for fusion biopsy. Back then, they did not have a TP attachment, which would let us do procedures. And this was a prototype which we developed with them. And we did the fusion similar to what we did in transrectal setting. And fortunately, my radiologist was very supportive, and they would mark every lesion with a 1 centimeter margin on Profuse, which was complementary software to Artemis. And then we'll transfer those images to Artemis. And under MR guidance, we'll plan the needle placement. How many needles do we need to ablate tissue focally with the margin? And then we'll put the needle under MR guidance and fusion guidance. Now, these kind of treatment planning softwares are pervasive, and most fusion companies offer such softwares. We looked at our data in select patient populations who got these kind of focal treatments, and we demonstrated that even with treating less tissue, first of all, by treating less tissue, we demonstrated that the functional outcomes were excellent. They have slight improvement in their urination. The SHIM scores were maintained, similar to our HIFU database. Significant decline in oncological outcomes, significant decline in PSA outcomes, and we maintained oncological outcomes similar to what hemiablation and hockey stick templates would do, even though we treated much less tissue by doing this approach. The next set of patients where I perform cryo is patients who need whole gland treatment. And a lot of those patients are usually elderly patients who are either ineligible or they're wanting to avoid radiation and they're not surgical candidates. In terms of disease characteristics, they could either have primary disease and radiorecurrent disease. I perform cryo for both anterior and posterior disease in this setting. And they need to have, of course, clinically significant disease. And they could be unifocal or unilateral patients who do not want repeat MRI or who wants to maximize their cancer control. I perform whole gland cryos for those patients, or if the patient has multifocal disease and they can only be treated with the whole gland modality. Again, you have to watch for an absence of any high-risk feature, extensive seminal vesicular invasion, extensive EP, and close proximity to urethral sphincter can lead to bad outcomes. So you have to weed those patients out. In terms of gland characteristics, and that's something you have to be a little bit cautious in, at least in salvage settings. If the prostate gland is too small, the cryo gets a little bit more trickier, and it's not as safe a procedure versus if the gland is more than 15 gram in size. So gland size between 10 to 15 gram, and for primary cases, it has to be less than 60 to 70 gram for whole gland cryo. For whole gland cryo, I do it cognitively, so there's no fusion system involved. using an ultrasound, I plan treatment at the mid aspect of the prostate. And usually 6 needles are enough in these locations to destroy, to completely freeze the prostate. After the needle insertion, I do a cystoscopy to make sure there's no needle in close proximity or through the urethra, and then put a urethral warmer to allow protection of urethra from the cryofreeze. And in sagittal view, I make sure the needles are inserted all the way to the base of the prostate so that I can get the ice ball extending from apex to the base. I use Endocare variable needle length. So you can measure the needle, the length of the needle, which is in the prostate, and determine the freeze length based on that. So this is a schematic diagram where the needle is placed on the posterior aspect of the prostate, and then the ice ball grows a little bit outside the prostate to get lethal temperatures inside the prostate. So this white line is actually 0 degrees centigrade, which is not lethal in the prostate. So you have to extend this white line at least 2 to 3 millimeters outside the prostate to achieve lethal temperatures at prostatic capsule if your lesion is posterior. So to conclude, cryoablation is a commonly used modality for prostate ablation, and there are 3 mechanisms for cell death with cryoablation, and it's with freezing, thawing, and endothelial damage. Focal cryo, in my practice, is usually reserved for patients with unifocal, unilateral, clinically significant disease. I perform most of these with MR guidance, with minimal impact on function, and still maintain good oncological efficacy. For whole gland cryo, I use it for multifocal patients who are elderly and where erectile function preservation is not a priority, as most of these patients receive permanent damage to their neurovascular bundles. Thank you.
Wonderful. Thank you both. Great talks, and a lot of info in there. So we have time for a couple of questions, if anybody would like to ask. So, Dr. Khanna, site-specific HIFU with margins versus quadrant ablation versus hemiablation for unilateral lesions. I guess this is about what sort of templates do you use for treatment. It's related to margin, so maybe both of you could tackle this. So Taimur first.
Taimur, yeah. Even you call me Taimur at work. So I think we have to bear in mind all the data about the lesion on the MRI versus the actual lesion on final pathology. And I think most of us, generally speaking, will use a 7 to 8 millimeter margin, sometimes bigger, so up to a centimeter as our margin around that lesion, which, depending on the size, tends to be at least a quadrant, sometimes a bit bigger. And I have used fusion systems to try and map out my margin with HIFU, and I find that because I've been doing it cognitively for so long, that when I placed my blocks, I was actually just naturally covering the margin already. But actually, in this setting, if you have a fusion system available, the key is to actually not get too tight, because the danger is when you can see it, you will start to get closer and closer to the actual MR lesion rather than what it probably is in real life. So I say at least 7 to 8 millimeters, possibly as big as a centimeter.
I agree with Taimur. You need at least 8 to 9 millimeter margin, and in most cases, you can easily do this cognitively. For example, if there's an apical lesion, you destroy the mid-apex quadrant, and that's easy to do. The example, for example, I showed, and I've noticed recurrent cases from other providers where they did template ablations and just didn't think that the medial aspect needs a little bit higher margin. And that was the example I was showing. So the margin has to be centered on your lesion. And if lesion is not a typical mid of the posterior zone lesion, then I think you have to adjust your margin accordingly. And a lot of time, especially in US, some physicians don't review their own imaging, and they do treatment based upon biopsy report and MRI report. And doing hemiablation in that setting without reviewing your own imaging can lead to higher recurrence risk because your margin is just not centered properly around the lesion.
Really good point. So see your MRIs, otherwise that tail will come back to sting you, the tail of the tumor. So just be very, very careful about looking at your own MRI scans. Last question for you guys. Do we see an abscopal effect, as there presumably with ablation there would be a lot of antigen release?
In this patient population which we have been treating in US now, we don't. I did a lot of bench research when I was at Hopkins as a research fellow on this aspect, and we studied immune parameters, and we demonstrated that there are definitely increase in immune parameters for the first 30 days, but it's not clinically relevant because they disappeared after 30 days. So you would not see, like if you would perform ablation in somebody with more advanced disease, you would not see clinically relevant response in their disease outside the prostate.
I mean, my answer is I think we don't know yet. So I think, as Abhinav said, we've got preclinical data that supports an immune response from these treatments, and potentially an immune response that actually triggers antibody production. So that may go beyond that initial period that we're talking about. And there's some very old data that shows that actually some patients with metastatic disease did get regression of Mets. We now need to obviously prove it clinically, and we are starting to see that we've got it with radiotherapy, potentially with improvement of treating local disease might help in Mets. We've done it twice now. So with ablation in the salvage setting, we've treated 20 patients with metastatic disease. It was a pilot to show that we could do it. Their functional outcomes were fine, and actually most were still alive a few years later. So I think it's too early on that cohort. But we've also just completed a 430 patient randomized controlled trial in primary disease, where 1/3 of patients had ablation despite having metastatic disease. And so Hash, who's obviously chairing, is CI for that study. It's called Atlanta. And hopefully that will answer a question on whether there is a benefit of ablation in this group. And this randomizing against surgery and radiotherapy and randomizing against standard of care. And we have to say that standard of care is changed a lot over the last few years, and patients are often being started on triplet therapy with chemo and some of the new ARTAs or ARPs. So actually potentially systemic therapy is very strong these days. So it'll be good to see what the results show.
Great, thank you both. I have the unenviable task of following all of those talks where my colleagues have covered a lot of the material already, but I'll do my best to try and keep it fresh as much as I can. So I'm going to, something's happened. Okay, can everybody see that?
Yes, sir.
Yes.
Yes.
Fantastic. Wonderful. So thank you very much for allowing me to chair the session, and it was really great to see a lot of people still hanging on to the end. So I'm very grateful for you all to take out your evenings. I know it's precious time with family. We're all conflicted, aren't we? I'm a urologist. I do public and private work, and I make money from that. And so I also bring in a lot of commercial money and academic money for the program. So you have to take what I say with these conflicts in mind. So what we haven't sort of spoken about is that, and I know India switched to the pre-biopsy MRI and targeted biopsy paradigm as well, is that we expend so much energy, time and effort and resources to finding that index lesions, usually just a tiny little thing in a corner. I know some men do have much more advanced disease. And then we throw all that effort away by then treating the whole prostate. And it just seems like a complete waste of that time, energy, and resource. And so identifying the right patient for focal therapy really starts with that highly accurate diagnostic pathway, which doesn't compromise on the accuracy, but equally doesn't lead to lots of harms through over biopsy and a huge number of biopsies, which can lead to issues of harm as well, and overdiagnosis of low-risk cancer. So there is a balance that we need to strike as we go forward to deliver that accuracy. And really, we know, and we've heard a lot now this evening, this afternoon, that MRI is highly accurate. It's not 100% perfect, but if you look at the data with a very accurate reference standard template mapping biopsy, we know that MRI misses very few grade group 3, grade group 4, and 5 cancers, if any at all. So good MRI, optimized, read by a great radiologist, is absolutely critical. And you miss very little. And the stuff that you do miss, which is grade group 2, you could argue is questionable, and I'll show you some data as to why that should be. We've gone through the argument already with Jiten and Arnas about systematic biopsies. And as we transition to targeted biopsies, one of the things that you need to be very cognizant of is that you will start to see risk shifts with targeted biopsy. And what I mean by that is your biopsy is going to be going through the center of a tumor, and it's going to be oversampling much of the higher grade center of the tumor. It might be full of grade group 4, and 1 or 2 needles might end up being grade group 4, 4 plus 4 equals 8, but surrounded by a sea of cores that show 3 plus 4 and 3 plus 3. Now, in the US and maybe in India, you would count that man as a 4 plus 4 equals 8, but he's not. He's absolutely not. That tumor is a 3 plus 4 or a 4 plus 3. And so you have to take into account all of the positive cores from that lesion and possibly from the prostate itself in order to give that grade attribution. Counting one core that has 4 plus 4 equals 8 purely in that core is, in my view, incorrect. And so you need to start to look at that so that you don't end up over-treating men as a result of targeted biopsies. And if you still want to include systematic biopsies, you really have to decide, what do you want to find? Why do you want to find it? And how do you want to find it? And most people, I think, are sticking to 12-core systematic. There are some people who use Ginsberg, 24 to 36 saturation or zonal or sectoral biopsies, and very, very few now are using the template mapping biopsy, where you take biopsies every 5 millimeters. And certainly I was a fan of that 10 years ago, but up until the moment we showed that MRI is highly accurate, I hardly ever do that template mapping biopsy now. We also need to use very simple tools at our disposal in order to reduce the biopsy burden and the overdiagnosis burden. And PSA density is a really strong biomarker. When you use it in conjunction with an MRI, so it has to be PSA density based on an MRI report, not pre-MRI, because PIRAD scores trump PSA density. But if you have an equivocal PIRAD score of 3 and you build into it PSA density, then a low PSA density with a PIRAD score of 3 predicts a high probability of absence of significant prostate cancer. And you can use whatever threshold you like. Most of us use 0.12 or 0.15 to determine which men don't get a biopsy. And again, I know colleagues who do 1 or 2 targeted biopsies, and then they take 24 systematic biopsies. And it doesn't make any sense. Your highest probability of finding disease is in the target, not in the normal tissue that the MRI has deemed normal. So by all means, take systematic, but really you have to start taking focal saturation biopsies. So as this study showed, your pickup rate needs to be, your biopsies really need to be incorporating up to about 5 or 6 millimeters, ideally, sometimes up to 10 millimeters of penumbra of the lesion. This is another study that showed the more biopsies you take from the target, the higher your cancer detection risk, cancer detection, and you probably need to take at least 4. We in our practice take 5 or 6 from each target. And it's not a fixed number. You have to take more from a tiny lesion. You can take 3 or 4 from a large lesion. So the smaller it is, the more biopsies you should really be taking from your target. This is a NYU study which reinforces the concept of focal saturation biopsy. So at least 4, ideally 5 or 6. And then a critical thing that you've probably heard from all of these talks is that focal therapy is not an alternative to active surveillance. It is complementary and it can be used in conjunction with active surveillance, but it really isn't an alternative. Men are willing to trade off between survival and side effects. So this is a study that we ran where we asked men what they were willing to trade off. So 550 men were given these options and they chose between various options of treatment and characteristics. And on average, men were willing to compromise up to 0.5% of survival for every 1% of improvement in erectile function. And men were willing to offset a 1% survival benefit for every 1% improved urine continence, defined by pad usage every day. And if you look at the SPCG, 5% absolute risk reduction in mortality, that is wiped out by these trade-offs that men are willing to make. So we often take a paternalistic attitude. We want to make men live as long as possible, but if you ask men, they don't want to live at any cost. Now, the beauty of focal therapy, as you've seen from the talks, is that you don't need to make that survival trade-off at all. You can survive just as long over a 10-year period, and we'll soon get 15-year data, I'm sure, and get a 5 to 10-fold reduction in side effects. So focal therapy, I used to show this slide and say that focal therapy was the middle ground between active surveillance and radical treatment, but really it's a complementary. It's not an alternative to active surveillance. If a man is suitable for that. And just to reinforce that data, this is our UK cohort and a big prospective registry. And the green bar represents men with low-risk disease. And as you can see, we treated a few at the beginning, but that bar really is quite small and ever diminishing as we start to treat more and more intermediate and high-risk cases. And as you can see, we've also adjusted the proportion of high-risk cases. You know, you go through a learning curve where you get braver and braver, and then you start to learn that some cases really are just not suitable for focal therapy, and you start to adjust. So that learning process over the last 15 years is also reflected in these graphs. And there is a green bar in this graph, but you just can't see it. It's tiny, because with cryotherapy, we really have learned from our mistakes with HIFU, and we're really not treating low-risk disease anymore. And in the last 2 years, I think I've treated 3 men with low-risk disease, and both of them had to bring a letter from their psychologist or their psychiatrist to me saying that they just couldn't cope with active surveillance. It would just drive them crazy, and they understood that what I was doing with HIFU carried no benefit to them whatsoever, but the alternative active surveillance for them psychologically was just unpalatable. So that's how strict we've become in permitting focal therapy for low-risk disease. So I don't think radical prostatectomy or radical radiotherapy practitioners go to that sort of length to avoid overtreatment. The other major point is we're increasingly starting to see that tumor visibility on MRI is really important. So prostate cancer tumor visibility from this study on MRI was a net result of many genes associated with increased proliferation, inflammation, and regulation of transcription. And MR visibility was associated with more aggressive phenotype to non-visible ones. And that's supported by Caroline Moore's data from UCL, which shows that a visible 3+4 confers higher risk of moving away from active surveillance and having treatment due to progression or patient preference, compared to a non-visible 3+4, which seems to behave just like a non-visible or a visible, certainly behaves like a visible 3+3 cancer. So visibility is really important. And this is supported again by the GAP3 Movember Consortium, which showed that visibility leads to a prediction of which men are likely to progress on active surveillance. And that means we can start to select men better for focal therapy based on visibility versus non-visibility. You've seen part of this table, and really it's unarguable now. I don't think I've had a single person stand up and say these percentages that you're showing are nonsense. And I think, in fact, we've probably underestimated the risk of incontinence after surgery. You saw the FARP randomized trial data showing about 40% pad use, and that's supported by this True North Movember UK prospective robotic prostatectomy case cohort of 1,000 patients, which shows 1 in 3 needed to use at least one pad, and a randomized trial of SABR radiotherapy to the prostate versus robotic prostatectomy showing 47% pad use. We just need to be honest with our patients. Nobody's doing bad surgery. The surgery and the radiotherapy leads to the outcomes that are there. It's an inevitable consequence of what we are doing. So nobody should take personal sort of responsibility to this, but they must counsel their patients. And it's up to the patients to then decide how much toxicity they're willing to accept or not accept, not ours. We have some comparative data. You've seen this graph before from an earlier talk. And as you can see, it's pretty equivalent, but propensity match studies do have residual confounders that we won't have taken into account. But this is reassuring, as is this, which is a 3-way comparison between focal therapy and radical radiotherapy and radical prostatectomy. And as you can see from the top 2 graphs, the patterns of failure are different, but the rates of metastases and death are very, very similar. Again, propensity match study, so there will be some residual confounders that we haven't taken into account. So do we have RCT data? So this is the first RCT, which is a pilot. It initially wanted to recruit 110 and went down to a target of 80 because it struggled. They had to extend their recruitment period because men were unwilling to be randomized. And as you can see, men really just wanted focal. And when they were allocated radical, 1 in 5 dropped out of the radical prostatectomy arm because they really didn't want it, even after being counseled for randomization. The FARP study was much worse. Fantastic achievement, 213 randomized, but again, it was a real struggle. If you speak to Edouard Bacot, he really struggled. He had to extend the trial recruitment. And as you can see, 1 in 3 were non-compliant in the prostatectomy arm. They really did not want to have radical prostatectomy. And we carried out our own randomized pilot study. This is multi-center, led by Taimur. And again, we struggled a bit because it was COVID, but we had to lower our target down from 60 to 36, extend our recruitment period. And surprise, surprise, 22% after randomization to the prostatectomy arm didn't want to have it. So everybody keeps on saying you must have randomized trial data. There's some debate as to whether Albert Einstein said this, but it really does count for this. Is doing the same thing over and over again and expecting different results when you're getting the same thing again. And we have brought into standard of care in urology, not just in prostate cancer, in urology generally, innovations based on case series without randomized controlled data. And active surveillance is actually one of them. They tried to do a big randomized trial of active surveillance versus radical therapy. It was led by Laurie Klotz and Chris Parker, and they failed to randomize. We tried to randomize between LDR brachytherapy and prostatectomy, and both of these trials, Spirit in the US and Sabre in the UK, failed miserably. Both of these treatments, especially LDR brachytherapy, were brought in based on case series. And if you tell the radiation oncologist that this is the case, when they argue about focal therapy needing randomized trial data, they'll say, well, so what? Things have changed. We now need randomized trial data. So a lot of this is blocks which are not based on legitimate concerns, but simply to block new treatments coming through. And the EAU changed its guidelines last year from saying only trials and research to indicating that HIFU cryotherapy can be done outside of research and trials as long as you collect your data in a prospective registry. So we should continue to do that. Everybody should be collecting their data, whether you're doing radiotherapy or surgery, and reporting on those data honestly and transparently so we can always learn. But focal therapy, it's mandated that we collect our data. And lastly, there's a lot of debate about screening. And my personal view is that screening cannot be delivered across healthcare systems unless we have a reduction in the harms of treatment. So focal therapy is a pivotal factor in approving screening. And without focal therapy, we cannot do screening. So that's my personal view. And we've shown a huge amount of changes that reduce the harms, MRI, targeted biopsies, transperineal biopsy, and we're getting less morbidity from robotic prostatectomy, less morbidity from radiotherapy, from innovations there. We're getting improvements in survival for metastatic prostate cancer and active surveillance. And that last bit that's left is focal therapy. And so we've started a large £42 million screening study that will insist on centers delivering pre-biopsy MRI, which will be done as a screening tool, but also will have to deliver focal therapy as part of that integration with screening. And what we're hoping to do is weave all of that together and still show a survival advantage through the Transform study. But that will take probably about 15 years before we get the first results. And if we do have screening with MRI, so this is about screening in the community with a 10-minute MRI scan, maybe even 5 minutes, like we do for mammograms and breast cancer, then there will need to be a large investment in scanning capacity. We're already struggling with the diagnostic pathway, but as you can see, this is UK figures. We're going to need a lot of scanners and a lot of expertise. So that's a sort of a whistle-stop tour of lots of things that are going on in the field. The imaging paradigm has really led to a significant correction in the harms and benefits ratio. The adoption of pre-biopsy MRI should be universal now. Active surveillance should be the only option for low-risk disease and most grade group 1 disease, which might be just drifting over to intermediate risk category. Active surveillance is increasingly being used for grade group 2 and a lot of intermediate risk cancers as well. Focal therapy unarguably leads to a 5 to 10-fold lower genitourinary side effect profile, and a similar cancer control outcome with no compromise on survival and METs-free survival over a 10-year period. And focal therapy should be offered as a standard care option to eligible patients. But you really have to select them carefully. And the future of screening for prostate cancer will be heavily dependent on finding a visible MRI lesion, independent of PSA levels, and heavily dependent on tissue preservation options. Thank you very much.
Thank you very much, Prof.
Fantastic.
Can I ask a question?
Of course.
So I face this in clinic every day. So when we show that slide about the harms of prostatectomy versus focal therapy, is it fair to show the same slide to a 75-year-old and then to a 49-year-old? Is it fair to say that your risk of incontinence and impotency is same for a T2 disease?
It's a really good question. So I guess younger men have a lower risk of incontinence, and you have to say what your data shows, and you have to be honest with it. You shouldn't be quoting, Mani Menon or Ash Tewari, who, their case series were based on skinning, men with prostates who probably don't even have cancer. We'll probably reclassify these grade group 1 cancers in the future as no cancer. So I think it's important to still be honest. But yeah, I mean, I still don't think with low-risk men, you're probably still only going to get, as low as 20% incontinence risk. But yeah, it is lower. I agree.
And sorry. The other question I face is so across UK and Europe now, with increasing use of neurosafe and frozen section, it's now increasingly being understood. So long as disease is T2, it does not impact functional outcome, while earlier data was that even Gleason grade would matter in how you choose your margins around the prostate. But with now neurosafe and live intraoperative frozen sections, you don't bother. If it's not T2, it's fine. You take it out with all nerves intact. So how do you see that?
Yeah, I think the verdict is still not certain on neurosafe options. There is a randomized controlled trial called Neurosafe in the UK that has finished recruiting, and we await their outcomes. And like with most RCTs, I think we'll all be surprised when the data come out, and we'll all find something that will support our premise and our stance. But yeah, I think the case series are very reassuring, but we'll see what the RCT shows. There's a question from Abhinav, I think.
Yeah, hi Hash. Wonderful presentation. Thank you so much. Over the years, definitely I've gotten more braver in the patient population where I offer focal therapy. One cohort I still worry about is like men who present with prostate cancer in their 40s. And not that I doubt the efficacy of initial focal therapy. My concern is focal has, as 1 in 4 chance of redo ablation, and then some of them end up getting surgery or radical treatment down the line. And we have reviewed that even though early on I would counsel my patients that focal therapy does not burn any bridges and your surgical outcomes will be comparable, they're not. We looked at systematic review. We did a meta-analysis of all the series, and there's definitely higher risk of incontinence for surgery after focal therapy. So in that patient population, how comfortable you feel offering them focal therapy for clinically significant cancer?
Yeah, that's a really good question. So I guess younger men have most to lose from a poor quality of life. So there's that side of things. And we don't have long-term data beyond 10 years for focal therapy. So there's that point of view. So I think it's all down to counseling, isn't it? And I think the data on salvage prostatectomy, you just have to question a little bit, especially on a background of UK data now showing incontinence risk of 35 to 47% for primary de novo prostatectomy. I suspect if you compare because a lot of the case series of salvage prostatectomy after focal is from the UK, there is some variability. One series shows that actually it's very similar, but higher ED risk, similar incontinence risk. One other series shows that it isn't. The French series shows that you're getting good outcomes. So I think that has to be contextualized with what we now know radical prostatectomy confers in terms of risk, and we mustn't sort of be oblivious to the fact that actually we've completely underestimated the impact of radical prostatectomy on our patients. We've probably been misleading ourselves as a result of rather poor case series in the past, which haven't used proper proms. So I think it's a counseling effect, isn't it? I mean, it's
I agree. Thank you so much. I think this question I've asked you earlier, and this was like a couple of years ago, and I'm not sure if your approach has changed since then. Any role of biomarkers, either somatic testing or germline testing in this patient cohort? Like you have a 80-year-old with Peyroux 4 lesion with Gleason 7 asking for HIFU. Would you change your approach based on the would you first of all order germline testing or somatic testing like Decipher, Polaris, and would that make you change your approach?
So we don't at the moment, and I'd love to, get the companies to work with all of us, in getting more data on that, because we have the tissue, so we could easily invest in that and look at that. So at the moment we don't, but I suspect there will be a role for it in future. We just need to invest in those studies. Shall we have a last question from Taimur? Because everybody wants to.
No, it's a question to both of you.
Yeah, that'd be great.
It was on both topics, but I think the first one you've answered already is about counselling. But the second question I think is more interesting because the UK tends to not use any biomarkers. We just don't have any that really are available. And so it's a question on what would this biomarker need to show for us to do it when our data shows that probably when we now project those curves out to 10 years, that the rate of MFS is almost zero. So I'm just wanting to know what your biomarker is going to tell me that will change my decision making. And it's to both of you actually, what does it need to show? Because it's unlikely that your biomarker is going to predict that 1% of patients who will have METs at 10 years. Or is it?
It can.
Let Abhinav answer.
Let me answer this question. United States is a little bit less friendly towards focal therapy than UK is. And there are a lot of robotic surgeons and radiation oncologists who are always beating down our neck about focal therapy. So even though there's definitely huge advantage in terms of functional outcome, we try to focus more on oncological outcomes, right, for focal therapy in the US. And we try to select patients who would have no risk factors to do poorly. So I do order testing for that cohort of patients, like Decipher. If they have high risk Decipher, I would not offer them focal. I'm in the middle of my focal meeting in San Diego, and yesterday I discussed a case, and there was a 63-year-old white male, very healthy, no comorbidities, had Peyroux 5 lesion on the right lateral apex. Great HIFU candidate from location standpoint, wanted HIFU, adamant for HIFU, and his biopsy came back as 6.5 millimeter of grade group 4 disease from that lesion. All of the codes were negative. And I was debating, should I do HIFU? At some point, we know UK does high risk focal all the time and their outcomes are great. This guy might be a great candidate for that. Should we do it? Should we not do it? I ordered germline testing on him because NCCN guidelines dictate you order germline testing for somebody with high risk prostate cancer. Came back as PAL-B2. Now, what I did next still did not help this patient. However, in a scenario in US, I think that's a decision I could defend. The other decision I could not have defended. So I did prostatectomy on this patient. He presented to me 3 months later for post-op visit, doing really well from functional standpoint, but his PSA was 34. I repeated his PSA again, 34 again. He started with PSA of 11 before the surgery. After surgery, his PSA is 34. Got PET scan, he has multifocal osseous mets because he had PALB2 mutation. So now, I certainly did not help this patient by doing prostatectomy, and I would not have helped this patient by doing HIFU either. But in a place where focal therapy is not standard of care, I think I would have definitely been criticized more internally to do focal in that setting and ended up with a metastatic disease.
You did the right thing, and you avoided a bullet there.
Yeah.
Fantastic. Look, thank you everybody for hanging on for so long. I'm sorry we've overran. I'll hand back to our conveners and Professor Sujata to close the session.
Yeah. Thank you very much. And I have to thank Gopal for inviting such a galaxy of speakers, and especially Dr. Hashim. I'm always impressed with your talks, and it always makes me think that is it possible for me ever to bridge this gap? Because I practice in a public hospital, and among the 100 patients I see in a year with prostate cancer, I think 7 or 8 are just the ideal candidates for RP or RT, and the rest are all metastatic. And I don't know how and where, and do I have the means to actually access this group of patients who would benefit from focal therapy. But as you said, it has to be at least a thought process. And I had told you that we have a HIFU machine which was purchased in 2009, and it's just lying somewhere and nobody knows about it, and what are the specifications also about this machine. So this is the disparity where politicians dictate the treatment modalities. But I hope with public partner and private partnership we could do something. And I only one question to you, that I don't know, but this is hearsay, that the patient from the GP to come to a specialty does take a long time in the Western countries. So does this affect your program in some way?
Yeah, we don't have screening in the UK so a patient has to request a PSA test from their GP, and the GPs often put them off from having a PSA test because they are worried about the harms of screening with PSA. So we also have about 20 to 30% present with metastatic disease in the UK. So and it's a bit of a struggle for the patient to get through their GP. Once they have a PSA test and the GP refers them to secondary care, it's very quick because we have legal mandates. We have legal mandates to diagnose them within 28 days and treat them within 62 days of their referral. So the pathway works quite quick once you get into hospital, but the GP, accessing GP and getting the GP to convince you to do a PSA test is a completely different matter.
Yeah, so I think maybe we can think of something of doing things together, at least find a way where we could help the patients come from a different socio-economic mode, like apart who can't afford any corporate treatment. But yeah, I'm really thankful to Gopal for inviting each and every one of you, and it was an excellent talk, and I'm mesmerized by your thoughts and your talks. Thank you very much, and good night.
Thank you.
Thank you.
Thank you.
Thank you very much. Thank you very
Good
much,
night.
everyone.
Thank you very much.
Thank
Thank
you.
you, each one of you. Bye.
And good morning.
Oh, yeah. Good morning.